trouble you, make you sit too long. I'll breeze through. I don't want to go to too much
Sir,
detail into
excuse me,
each of
sir,
the...
1 second. I wanted to congratulate Dr. Anita. Your presentation was very lucid explanation of golden hour. Within that short time, you could make best use of that golden hour. And your last but one slide, that neonatal plea, that was awesome. And all your slides were fabulous. Very nice presentation, very useful. And I congratulate you on your presentation. Very nice. So sorry to interrupt you, sir. Please continue.
So the topic is obstetric analgesia for a positive birthing experience. I think when my kid was born, I tried to be as positive as I can, but that didn't help my wife. Then I realized it's not me who should be positive, the person who is actually giving the birth. So it all began in 1591, where a lady was burned for asking some pain relief in Edinburgh. Then the proverb says that in the Garden of Eden, God punished Eve for eating a forbidden fruit, and then said, "In sorrow thou shalt bring forth children." So there is a notion that for the last 300 years it's been like no pain, no baby delivery. So even WHO conducted a survey which said in the last 3 decades, people in remote areas still believe that without pain there is no labor. So that formed the basis for 1800 years in the past. John Snow in 1853, he was the first person. He's termed as father of anesthesia. He actually gave chloroform for Queen Victoria's birth in Buckingham Palace. Eighth child was born using chloroform. That's the first when somebody tried to give some pain relief for analgesia. Then developed the pain pathways and continuous caudal infusions and continual lumbar epidurals, which came into existence, which we still improvise and follow today. So there's two types of pain. One is the visceral pain and the somatic pain. Don't want to go into too much details. First stage, active and latent phase. Second stage, somatic pain, which is S2 to S4. So the pain intensity goes up as we go from the latent to active phase and the second stage. So in the McGill pain scores, the causalgia is 40, which is a digit amputation. So nulliparous patients and primiparous untrained, they experience pain up to level 40, which is a digit amputation without any anesthesia. So it's as bad as that. Multiple analgesia options are there. So going into non-pharmacological options like complementary alternate therapies in the next slide, going into pharmacological options like non-regional techniques like inhalational Entonox and Sevoflox, and regional techniques like epidural, patient-controlled epidural analgesia, and combined spinal epidural and spinal analgesia. So alternative medicine techniques, these come as a psychological things like hypnosis, breathing techniques like Lebois and Lamaze technique, relaxation therapy, yoga, homeotherapy, aromatherapy, hydrotherapy, acupuncture, massage, and transcutaneous electrical nerve stimulation. So ideal techniques doesn't interfere with the progress of the labor and delivery. It's safe for both. There are two patients at risk. One is a mother, the other one is an infant. And it provides the flexibility in changing conditions, changing the nature of the labor, minimizes undesirable effects, and constant pain relief is provided throughout. Some non-pharmacological techniques like underwater delivery still followed in some of the cities like Chennai, where there's no advantage in labor outcome or reduction of the need for analgesia. Only thing which was shown was epidural analgesia. The need was delayed for 30 minutes, and most of the trials lack safety, and there are some reports of asphyxia and fetal injuries with hydrotherapy and underwater deliveries as well. A slide on TENS, which is an electroanalgesia method. It follows the great control theory of pain. It inhibits the nociception at different levels. So in the first stage of labor, where we keep the 4 pads at T10 to L1, in the second stage, S2 to S4, the pads are placed and it inhibits the nociception and the gate control theory of the pain. So some myths around the labor epidurals. In the last 2 decades, there's many impact studies have shown that there's no association between the C-section and epidural administrations. So there's a meta-analysis and nine impact studies together formed by Siegel and colleagues, which involved 37,000 parturents where epidurals were placed. Ultimately, it showed that there is no increase in rate of cesarean section or deliveries due to cesarean section during the increased period of usage of epidural analgesia. This graph shows all the 9 studies depicting the graphs, where the epidural analgesia rate is on the x-axis and the cesarean section delivery rate is on the y-axis. There's only a marginal decrease in some studies and marginal increase. There's not even a single study which showed positivity that epidural leads to cesarean sections. In terms of evidence regarding epidurals, the incidence of cesarean section is not affected. The incidence of instrumental vaginal delivery was increased in the past, but with the amount of density and concentration of the local anesthetics used, the instrumentation deliveries have come down as well. Duration of first stage of labor, no difference, and the duration of second stage of labor with density and concentration of the local anesthetic, it's slightly prolonged. All these results are conflicting. The confounding factors being the density of neuraxial analgesia and the sensory blockade and motor blockade, which leads to decreased maternal ability to expulsive efforts with uterine contractions. So this is a slide which shows multiple studies where systemic IV opioids and epidural opioids have been given. On the right side, we see all the odds ratios shifted towards the right, where systemic opioids were used. So clear-cut slide which shows epidural analgesia and epidural opioid intake is very definitive and has a very high safety profile and less side effects. Other methods include Entonox, which is a 50% nitrous oxide and 50% oxygen that provides rapid, safe, short-term relief. It's very reliable. Whenever the woman faces the contraction, they inhale a big breath of Entonox, and it shown to decrease 40 to 48% pain relief for most of the patients. It's very simple to use, simple mask, easily administrable, patient controlled. So patient uses herself. It takes 40 to 50 seconds to get the effect, and the effect lasts for 1 minute. So every contraction it can be used. There's minimal side effect profile for this. The other one is Civox. It's slightly more complicated because anesthetist should be involved in this. It uses a 0.8% sevoflurane. It has short onset and short offset. Best suited inhalational agent, but it needs a lot of expertise and a lot of equipment to be used in the daily patients. The other forms are patient-controlled analgesia, where a button is given to patients. PCA fentanyl is also used in many other conditions where spinals and epidurals can't be readily administered because of bleeding effects, coagulation effects, or any other side effects. There's no difference in the ABGA scores or the need for naloxone in the newborn when epidural techniques are not used, so fentanyl can be used in those kind of situations. Remifentanil is the newer one where it's widely used in the West. It's slowly coming into existence in our cities as well. It's ultra short acting opioid, slightly different metabolism with no accumulation either in mother or in the baby. There is placental transfer, but there's extensive fetal metabolism as well. Close monitoring can be done to maintain the sedation score, respiratory rate, and SATs. Oxygen supplementation should be given throughout the remifentanil PCA. So it's very easy to administer. It's patient controlled, and whenever the patient presses button, there is some amount of psychological satisfaction along with the medicine as well. It does act as a bridge to regional anesthesia, easy to administer and safely can be given because we have a lockout interval, we have a bolus dose, and we have a time for the next dose. Couple of other blocks can be used. One is a paracervical block. The aim is to block the transmission through the paracervical ganglion. 2 injections, 8 o'clock and 4 o'clock. It does have some side effects. It's used in the first stage of labor. It doesn't work in the second stage. Some side effects include fetal bradycardia, postpartum neuropathy and infection, and systemic local anesthetic toxicity. The other one, which is slightly easier to administer, slightly easier to give, this can be given for episiotomies as well. It blocks the pudendal nerves, S2 to S4. It's a pudendal nerve block. Provides analgesia in the second stage of labor. Helps in spontaneous delivery and outlet forceps delivery as well. Slightly lesser side effects compared to the paracervical block. The ideal technique has been the epidural analgesia. So many advances in the epidural analgesia as we go into theory of Darwinism. So over the past 90 to 110 years, we started off with spinals in 1890. Then in 50 years, we evolved into continuous epidurals. Then we went to continuous spinal epidurals, and then we went into the current management and gold standard is dual puncture epidural, which is the newest and safest and most ideal form of epidural analgesia. So this shows the Darwinian adventure where we start off with epidural, then continuous spinal epidurals, and dual puncture epidurals. So the epidural technique, we go into the skin ligamentum flavum and put a needle into epidural space. There we deposit some drug. Drug doses are being mentioned here. The only difference between epidural and dual punctural epidural, which is a gold standard and most advanced and high efficacy in the recent times. In the last 2-3 years, it's become into existence. We use a 16 gauge 2 needle and then a spinal needle inside that. So what we do is we go into the epidural space and we use the spinal needle to just go into the subarachnoid space and then come back. We don't administer any drug into the spinal space. That creates a rant in the spinal entry point, which is the subarachnoid space. So whatever drug we give in the epidural space, some amount of drug, around 8 to 10%, has shown to go into the spinal space. So that gives immediate and effective sacral analgesia, S2 to S4, to maintain the second stage of the labor. So this is a dual puncture epidural technique where a catheter is passed into epidural space and the needle is passed into the spinal space and taken back. So whenever dye was injected into these kind of comparison techniques like epidural, dual puncture epidural, and combined spinal epidural, there's not much side effects because in the dual puncture epidural, because there is not much amount of dye leak in that. The many technique advantages with dual puncture epidural. Location can be confirmed, faster offset, faster onset, sacral spread is good, bilateral spread is good, and catheters can be tested, which is not possible with the combined spinal epidural. Other disadvantages like fetal bradycardia, which is 6 to 8%, uterine hypotonus, which is 8 to 12%, and workload in terms of continuous monitoring, the nurse going to have a look at the catheter, administering different boluses, all these things are not needed with the dual puncture epidural. Other forms of epidural analgesia, patient-controlled epidural analgesia, and continuous epidural infusion. So slightly more expensive, slightly more time-taking, and need nurse support and doctor support to give boluses at different doses. With the recent advances, virtual reality has also been added to the non-pharmacological technique, where it demonstrated that both meditation and interactive virtual reality experiences significantly decrease the NRS, which is the numeric rating scale of the pain, by 26 and 19%. It actually gives a meditation and calming nature and minimizes the physical effort. So absolutely no side effects for these kind of things. The other one is the artificial intelligence. It has the potential to monitor real-time parameters, predict the pain intensity, and advanced systems like patient-controlled epidural analgesia, which can be integrated into a central monitoring system. These innovations aim to improve the safety, efficiency, efficacy, and satisfaction of the patient. So the take-home points, we avoid single-shot spinal analgesia techniques these days. Optimal analgesia during childbirth must be tailored for both two patients at stake here. One is the mother, one is the fetus. It should begin as soon as the patient enters the birth pathway. Dual punctural epidural is the most ideal and advanced technique for labor analgesia. So positive birthing experience is a basic right for every woman. So when it is easy, there is no right on us or no rule for us to deny that. So everybody should have a calm, nice, and easy birthing experience. We are not in that era of 1800s and 1900s anymore.